let me invite Dr. Suresh Babu, who is a nephrologist from United Kingdom, to actually show his case, because that would really, it's a good case to actually discuss, and it's like a case that what we need to do after that, after presenting this case. So jointly we will be discussing it after the last talk. So he would be speaking for the next 8 minutes, and then after that I will be presenting a case, and then we'll have a joint discussion. So over to you, who is a senior nephrologist at the Royal Wolverhampton Hospital NHS Trust in United Kingdom.
Thank you, Dr. Khanna. It's a great pleasure to be among such wonderful people, and I really wish, people in Delhi are very lucky because of such a wonderful service, interventional nephrology service. And in the UK, all interventions for fistulas are done by interventional radiologists and the vascular surgeons. Nephrologists, as such, we do the tunnel lines, biopsies, and the temporary lines for our patients. All tunnel lines in our center are done by us. But anything more than that, it's up to the interventionalist. So I'm going to share this very interesting case, which we got into trouble very early in the dialysis life. Patient is a 32-year-old female. She's type 1 diabetic since the age of 10. She has all micro and macrovascular complications of diabetes with retinopathy and neuropathy. She had extensive laser treatment for the eyes. She's blind in one eye and partially sighted in the other eye. She had diabetic nephropathy, and a baseline GFR was around 35 mils per minute. So CKD was progressing. We anticipated that maybe she might need dialysis in the next 2 to 3 years, but unfortunately she had admitted with sepsis in another hospital nearby. She went to visit the relatives and got admitted with sepsis. She spent 4 to 5 weeks in intensive care, at which she developed AKI on the background of CKD and never recovered her renal function since then. The dialysis, obviously, in the ITU was done with the perm care, with the temporary line. And then when she came to our center, because as she was local to us, first thing we did is we did a right-sided tunnel dialysis catheter, and we referred our patient to the vascular surgeons for a permanent vascular access. The bilateral Doppler showed small-sized radial veins, and there was a good brachial vein, and they decided to do left brachiobasilic AV fistula with good flows. Was going on smoothly. In between, until she got the fistula done, she had to have multiple lines in both femorals and right-sided neck. Left side neck, we didn't touch it, but she had catheters in all other 3 central veins. Even though we tend to avoid and get the fistula first, but this patient, there was a long delay because multiple cancellations. She was not turning up to the surgical vascular clinic, and sometimes even canceled the theater, had to be cancelled the theater list. And so since the time of fistula, dialysis was taken care of. Access was not an issue, but she had multiple hospital admissions with both hypoglycemia and DKAs, which did, and also the COVID pandemic was in thing, and that delayed some of her work up for transplantation. Finally, when we worked up for transplantation, she had a very low ejection fraction and was not suitable candidate for transplant listing, they said. And then we always wanted to look for other options. What if this fistula, if she gets into trouble? And we did counsel about peritoneal dialysis. She also had some diverticulosis and diabetic gastropathy, and patient was not keen for PD, so hence she was not a candidate for peritoneal dialysis. In April this year, left arm started swelling, and the Doppler showed left subclavian vein stenosis. She had 1 angioplasty with good results, but the stenosis recurred, and second time when they tried to do the angioplasty, it failed because the patient could not tolerate. It was very painful. She screamed, and we had to get her out of the room. We thought under sedation, we will attempt a further angioplasty. But within that time, she fistula clotted, not surprising, and we couldn't declot the fistula. This happened on a Saturday. We couldn't dialyze at all. And Sunday we did, we got her admitted, we treated with potassium binders, made the potassium safe. And on Monday, she had a central venogram which showed bilateral external iliac veins were occluded. Right IJ was narrow. We could not put a tunnel catheter in the right IJ. And the right subclavian vein was patent. And we know the left subclavian anyway is stenosed. So what we decided, usually we have a vascular MDT on a Monday morning, but we called this urgent MDT after this venogram and then decided what's the best way to proceed. And our vascular surgeons, a couple of them, after discussions, they decided the best way to do is left to right necklace graft. We've had this done in the past, but not for such a young patient. Within 3 years of dialysis, we had to get to this stage of using a necklace graft. And she had the graft on Friday, but for that we had to put a temporary, because she was not safe to go to theater, we had to put a right IJ line, dialyze for 2 consecutive days and take the line out. And Friday she had this procedure. And so far the dialysis is going on quite well. Now we are really concerned about the vascular access, and we are talking with the transplant team again with further cardiac investigations to see, yes, she's a borderline, but whether we can somehow look at the transplantation again. I just want to show this picture of the necklace graft from left to right. This is one of our recent dialysis session. We took this picture. So I think what I would, in the UK, we always go for fistulas and not the grafts. I was wondering the experience from other parts of the world, whether in this particular situation or in select individuals, whether graft can be a preferred option instead of fistulas. And also now, yes, we've got this necklace graft, but there is always chance that it might stop working. And if it does, what are the options do you think the team might suggest? So I'll open the floor for discussion.